Good afternoon, everyone. I'm Stephanie Maselli, Media Officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us today for a webinar for our recently released report, Addressing Sickle Cell Disease, a Strategic Plan and Blueprint for Action. And you can download the report and related resources at nationalacademies.org/sickle cell disease. The slides and recording of this webinar will be available on that page as well, typically within the next few days. For those of you who are not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study's statement of task. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. I have with me several members of the committee to discuss the report. But before I introduce them, I have a few reminders. This webinar is scheduled to last 1 hour. We'll start with a presentation summarizing the report by the committee members, and then we'll open it up to any questions that you may have. If you have a question, you can simply click the Q&A button on the bottom of your screen. And should you have technical issues during this webinar, please contact Zoom technical support at 1-888-799-9666 and select option 2. And finally, I'd like to introduce the members of the committee that wrote the report who are here with us this afternoon. We have our committee chair, Dr. Marie Claire McCormick from Harvard University. We have Dr. Enrico Novelli from University of Pittsburgh, and Dr. Kim Smith-Whitley from Children's Hospital of Philadelphia. And with that, I'd like to turn it over to Dr. McCormick.
Thank you. I too welcome you to this presentation of our report. It was a very hardworking committee and it was a lengthy report. And so we're really delighted to be able to have this public release webinar. Next slide. As you're looking at the committee members, it was a very diverse committee with a variety of skills that include engineering, it included ethics, and included people who were familiar with disease surveillance, it included people who were quite familiar with the treatment of individuals both as adults and as children, as well as people who are familiar with emergency services and the economic issues that we were charged to deal with. In addition, we had people who were quite fluent in the issues of racism and stigma. So it was a very diverse group. Go on. For those of you who are not familiar with this, sickle cell disease is a genetic mutation that was identified in 1910. It is a recessive disease, meaning you have to have 2 mutations in order to have a full-blown disease called sickle cell disease. 100,000 people currently are living with sickle cell disease in the United States, and that is dwarfed by the number of people worldwide who are experiencing the problem with sickle cell disease. About 1 to 3 million Americans have one gene for sickle cell disease called sickle cell trait. And so about 8 to 10% of African Americans have sickle cell trait. Next. Historically, the population affected by sickle cell disease has contended with racism and implicit bias within and outside the healthcare system. Socially, they are stigmatized because of cultural beliefs and a lack of general understanding of the disease. One of the major characteristics of sickle cell disease is pain. It can be chronic and acute and is lifelong. We heard incredibly dramatic stories from those who participated in our public sessions about the impact of this pain on their lives. We also discovered that pediatric and adult healthcare delivery varied considerably. Specifically, pediatric healthcare was relatively well organized and adult health care was not. Mortality with sickle cell disease increases with age, as it does with all of us, but in this case, it's a premature mortality that reflects the damage done to organs by the sickled cells. And finally, there are limited resources to address sickle cell disease across the spectrum, from research on treatments to care delivery to the appropriate development of health professionals and so forth. Next. So to address this, the Department of Health and Human Services Office of Minority Health requested the National Academies of Science, Education, and Medicine to develop a strategic plan and a blueprint for addressing sickle cell disease in the United States. The plan should include a review of the epidemiology, health outcomes, genetic implications, and societal factors associated with sickle cell disease and trait, and to examine serious complications such as stroke, kidney, heart problems, and others. Also, there was a review of current guidelines and best practices for the care of sickle cell disease where they exist. To the extent possible, the economic burden associated with sickle cell disease was to be estimated. And finally, we were to review the current federal, state, and local programs related to sickle cell disease and trait, including monitoring, surveillance, treatment, and care, research, and others. Next. If that weren't enough, the report should then synthesize this information to provide guidance on priorities for programs, policies, and research, and recommendations as appropriate. In particular, it was regarding the limitations and opportunities for developing national sickle cell patient registries or surveillance systems, barriers in the healthcare sector associated with sickle cell disease and trait, including access to care, high quality care, workforce development, pain management, and transitions from pediatric to adult care. It also included needed innovations in research, particularly for curative treatments such as gene replacement editing, and an increasing awareness and enrollment of sickle cell patients into clinical trials. Finally, the expanded and optimal role of patient advocacy and communication groups should be highlighted. The committee guidance should then be formulated around strategic objectives, a strategic plan, and action steps or recommendations, a blueprint. Throughout all the deliberations, the committee would give enormous importance to the ethical issues related to sickle cell disease and sickle cell trait. And we will go through the recommendations in detail. In order to address this concern, we did an extensive review of the literature, although it was primarily US-based because we were dealing with a US agency. We had 5 committee meetings in which we deliberated the information that we were receiving. We had 5 public data gathering meetings, and in these we received input from patients, patient advocates, providers, pharmaceutical manufacturers, research, and representatives of relevant SCD programs. And these were often extremely dramatic meetings. And finally, we visited the Georgia Comprehensive Sickle Cell Center located at Grady Memorial Hospital in Atlanta. Next. In thinking about how to approach this problem, we had sort of 3 main conceptual approaches. One was lifespan. There was a need to identify the needs and specific challenges of individuals with sickle cell disease, knowing that they may vary according to different stages in life, but also that what preceded individuals in one phase of their life may have grave implications for later on. Secondly, the experience of sickle cell disease is shaped by sociocultural factors, environmental factors, and socioeconomic factors, which can exacerbate the disease's impact for people from racial and ethnic minorities who are living with the disease. And finally, in thinking about how care should be organized, it should be person-centric. Sickle cell disease must be managed as a chronic disease, which requires an ongoing, person-centric, collaborative approach to care management. The report is organized into 9 chapters and appendices which deal with some of the additional information that we gathered. In Chapter 2, we deal up front with societal and structural contributors to disease impact. Chapter 3, we look at screening, registries, and surveillance. Chapter 4 details the complications of sickle cell disease and current management approaches. Chapter 5 examines healthcare organization and use, although we'll also say we looked at things like the educational services that may be useful to young children. In Chapter 6, we looked at the delivery of high-quality sickle cell disease care with a prepared workforce and how to get there. Chapter 7 deals with developing and delivering the next generation of therapies. Chapter 8 deals with community agents engagement and patient advocacy and the importance of community engagement. And Chapter 9 lists out the strategic plan and the blueprint for sickle cell disease action. Next. The impetus for action really stems from some of the things we've already mentioned. First, sickle cell disease exemplifies the experience and consequences of health disparities and inequities in the United States. And secondly, the burden of sickle cell disease is immense for their individuals and their family, and for the community, for larger society. It's one of the major causes of disability-associated life, loss of disability-associated years lost among diseases that are much more prevalent. And for that, I will now turn it over to Kim.
Thank you. The committee determined that, at a minimum, the strategic plan should ensure that the sickle cell disease population receives the same high-quality health care to which every American is entitled, but recognizes that it will take much more to bring the vision for the strategic plan to fruition. The foundational principles on which the strategic plan is based was taken from the 6 aims for the healthcare system identified in the IOM report, Crossing the Quality Chasm. Those 6 principles are safe, effective, patient-centered, timely, efficient, and equitable. The committee, however, believed that due to the history of marginalization and racism that has affected the majority of the population impacted by sickle cell disease, it was important to add a 7th principle, ethical. Next slide. This slide shows the 8 strategies or pillars for attaining the committee's vision for improving sickle cell disease care and the underlying foundational principles. The image is not entirely readable, but I will discuss, along with Dr. Novelli, all of the individual recommendations outlined in this strategic plan. Next slide. So 8 strategies or pillar support the vision. I'm going to be addressing the first 3, which are establish a national system to collect and link data to categorize the burden of disease, outcomes, and the needs of those with sickle cell disease across the lifespan. We really were very much committed to a lifespan approach. Strategy B, establish organized systems of care that ensure both clinical and non-clinical supportive services to all persons living with sickle cell disease. Strategy C, strengthen the evidence base for interventions in disease management and implement widespread efforts to monitor the quality of sickle cell disease care. Next slide. Increase the number of qualified health professionals providing sickle cell disease care. Improve sickle cell disease awareness and strengthen advocacy efforts through targeted education and strategic partnerships among key stakeholders. Address barriers to accessing current and pipeline therapies for sickle cell disease. Implement efforts to advance understanding of the full impact of sickle cell trait on individuals and society. And finally, establish and fund a research agenda to inform effective programs and policies across the lifespan. Next slide. So for our first area of concentration on data gaps and newborn screening follow-up issues, the committee found that important data gaps exist for sickle cell disease. Longitudinal data collection systems would provide data for decision-making and evaluation of needed changes in sickle cell disease care. Inconsistent communication of sickle cell disease results to parents, guardians, and providers, and in follow-up once diagnosed across state newborn screening programs. Thus, newborns with sickle cell disease and their families do not receive standardized quality care and familial support across state programs. Also, this exists with sickle cell trait as well. So being able to address these inconsistencies would, even at early in life, improve quality of care. Next slide. So the action steps for our recommendation to establish a national system and collect and link data to characterize the burden of disease, outcomes, and the needs of those with sickle cell disease across the lifespan are: develop state public health surveillance systems to support a national longitudinal registry of all persons with sickle cell disease. And when you see the years coming after the action items, these are the timelines that the committee recommended as well. Within the first 1 to 2 years, develop a clinical data registry for sickle cell disease. Establish a working group to identify existing and disparate sources of data that can be immediately linked and mined. Next slide. So this next issue was around models of care, academic performance, and neurocognitive function. Vaso-occlusive crises or painful episodes and frequent hospitalizations increase the risk for learning difficulties, poor performance, and absenteeism among children. Educational supports may be needed, but parents and others may be uninformed of the process for obtaining them. Also, silent cerebral infarcts into adulthood may impact cognitive function, and vocational rehabilitation services may help to open doors to job markets. Existing SSI disability qualifications for sickle cell disease do not reflect the full impact of the disease on functional status. Criteria penalize patients that receive high quality care that then reduces the disability, but then they lose access to services. So our action steps on the next slide. One more thing, I'm sorry, I misplaced an extra finding. And in the model of care, we really need to address a comprehensive multidisciplinary system of sickle cell disease care that includes a collaborative process for delineating the elements of care and providers. Models exist to learn from. We've seen them in cystic fibrosis and inflammatory bowel disease. Comprehensive sickle cell disease centers could be formed and certified. Novel payment approaches are needed to support a coordinated system of sickle cell disease care. And now for the action steps that are related to our recommendation to establish organized systems of care that ensure both clinical and non-clinical supportive services to all persons living with sickle cell disease. We had a long discussion that restructuring of care delivery would also provide a platform for patient advocacy groups and community-based organizations that have played an integral role in driving policy and much needed programming for the sickle cell population. And this is a unique way to bring all stakeholders together to address not only the clinical, but the non-clinical aspects, such as case management and care coordination, health education, transportation, translation, and interpreter services. They're all important to provide equal access to care. And the action steps are to develop educational materials to provide guidance to a broad range of education staff and providers to support the medical and academic needs of students with sickle cell disease. Review SSI disability insurance qualifications. Expand and enhance vocational rehab programs for individuals living with sickle cell disease. Convene a panel of relevant stakeholders to delineate the elements of a comprehensive system of sickle cell care that can be applied nationwide. Develop and pilot reimbursement models for the delivery of coordinated sickle cell disease healthcare and support services. Next slide. We went on to address morbidity, mortality, and quality of care. And our findings were that there is an excess sickle cell disease mortality in adulthood attributed to not receiving appropriate care or high quality care. Quality improvement efforts in sickle cell disease have lagged behind those in other diseases. There is a need to generate evidence to address gaps and standardize and promote the delivery of high-quality sickle cell disease care. Quality indicators for sickle cell disease are needed that are consensus-driven. And by consensus, we mean with a voice for all stakeholders. And sickle cell disease could benefit from the development of quality improvement collaboratives. So our action steps for our recommendation to strengthen the evidence base for interventions in disease management and implement widespread efforts to monitor the quality of sickle cell disease care through funding efforts to identify and mitigate potentially modifiable disparities in mortality and health outcomes. A good example is maternal mortality in individuals with sickle cell disease that has been addressed in West African countries, and some of the applications could be applied here in the US. Develop and track a series of indicators to assess the quality of sickle cell disease care. Fund and conduct research to close the gaps in the existing evidence base for sickle cell disease care. As Marie pointed out early on, the first patient living with sickle cell disease was described in the US in 1910. That individual probably received the same supportive care for his pain that we are providing in 2020. So we really need to do this work. And also foster the development of quality improvement collaboratives and require the reporting of expert consensus-driven sickle cell disease quality measures and other metrics of high quality healthcare for persons with sickle cell disease. And then Dr. Novelli will report on our last set of recommendations.
Thank you, Dr. Smith-Whitley. Strategy D is aimed at addressing workforce issues for care for individuals with sickle cell disease. And the committee found that a number of health professions, training and research support opportunities exist that could be better used to incentivize professionals to provide care to individuals with sickle cell disease and to engage in research for sickle cell disease. Health professional training could be enhanced through a sickle cell disease academy, and the HIV Academy could be one model. And fellows in hematology oncology training programs have reported few mentorship opportunities, especially for sickle cell disease. To address strategy D, which is to increase the number of qualified health professionals providing sickle cell disease care, the committee recommends the following action. The National Institutes of Health should disseminate information on loan repayment programs opportunities to incentivize healthcare professionals interested in conducting research on sickle cell disease. HRSA should add populations with sickle cell disease as a designated population for health professional shortage area under the National Health Service Corps program and create a loan repayment program for healthcare professionals working with sickle cell disease populations. And the time frame, 1 to 2 years, is to disseminate information about the existing programs, in 3 to 5 years to develop criteria for loan repayment. Health professional associations, such as the American Society of Hematology, the American College of Obstetricians and Gynecologists, and many others, and organizations for other relevant health professionals, such as advanced practice providers, nurses, and community health workers, should convene an Academy of Sickle Cell Disease Medicine to support sickle cell disease providers through education, credentialing, networking, and advocacy. And finally, for the third point, health professional associations and graduate and professional schools should develop early and effective mentoring programs to link early career health professionals with seasoned providers to generate interest in sickle cell disease care. Strategy E, as Dr. Kim Smith-Whitley said earlier, focuses on the general lack of awareness and understanding about sickle cell disease. And the committee found that lack of public knowledge and understanding about sickle cell disease continue to perpetuate stigma that confronts individuals living with the disease. and there's a need for culturally and linguistically relevant educational material for individuals living with sickle cell disease, especially on care management approaches and emerging clinical research. And several community-based programs, such as camps, peer mentoring, and transition programs, have been proven to be effective in supporting care management for those with sickle cell disease. And so effective programs need to be identified and replicated. To accomplish strategy E, which is to improve sickle cell disease awareness and strengthen advocacy efforts through targeted education and strategic partnerships among key stakeholders, the committee recommends the following action steps: to engage with media and to improve the awareness about the disease and address misconceptions about the disease and those that are affected. The Department of Health and Human Services, in collaboration with state health departments and healthcare providers, should partner with community-based organizations and community health workers to engage the sickle cell disease population in designing educational and advocacy programs and policies, and in disseminating information on health and community services to individuals living with sickle cell disease and their caregivers. And for the third bullet, the Department of Health and Human Services, in collaboration with Health Professional Association, healthcare providers, and other key stakeholders, should partner with community-based organizations and patient advocates to translate and disseminate emerging clinical research information to people living with sickle cell disease and their families in order to improve health literacy and empower them to engage in the care and treatment decision-making process. Strategy F pertains to developing and ensuring widespread access to novel therapies. The committee found that the high cost of novel curative therapies for sickle cell disease pose a substantial barrier to access, which should be addressed to ensure access for all individuals with sickle cell disease. There are several unanswered questions about novel curative therapies, such as stem cell transplantation or gene therapy. An emphasis should be placed on counseling patients on the uptake of therapies that are high risk and equipping them with tools and knowledge that foster provider-patient shared decision-making. Several entities such as PCORI, the American Society of Hematology, the FDA, the NIH, have existing activities to foster patient-centric clinical trial design and to encourage participation in clinical trials. And best practices from these efforts need to be standardized and scaled. In order to address barriers to accessing current and pipeline therapies for sickle cell disease, the committee recommends the following 3 action steps. Number 1, the Department of Health and Human Services should encourage and reimburse the practice of shared decision-making and the development of decision aids for novel, high-risk, potentially highly effective therapies for individuals living with sickle cell disease. So timeframe is 1 to 2 years to identify and develop criteria for the use of the new medications, and 3 to 5 years to develop guidance for shared decision-making and tools for implementation. Second bullet, the Centers for Medicare and Medicaid Services, in collaboration with private payers, should identify approaches to financing the upfront cost of curative therapies. And number 3, the National Institutes of Health, the Food and Drug Administration, and the pharmaceutical industry, and the research community at large should establish and organize systematic approach to encourage participation in clinical trials by including effective individuals in the design of trials, working with community-based organizations to disseminate information and recruit participants, and conducting other targeted activities. Strategy G focuses on sickle cell trait, and the committee found that misconceptions about sickle cell trait perpetuate stigma about trait carriers and associated risks of sickle cell trait status. Research indicates that sickle cell trait may be a risk factor for health complications and sudden death in certain rare extreme instances. And so there's a need for further studies to understand the extent of these complications and how to eliminate them. Sickle cell trait status information is collected as part of newborn screening in all the 50 United States, the District of Columbia, and US territories. However, communication of trait status is not standardized, and passed along to individuals or families across the lifespan for use in future decision making. For strategy G, the committee recommends implementation of efforts to advance understanding of the full impact of sickle cell trait on individuals and society. First, the Office of the Assistant Secretary of Health should partner with community-based organizations, the media, and other relevant stakeholders to disseminate information to promote awareness and education about the potential risks associated with sickle cell trait. Second, the National Institutes of Health should fund research to elucidate the pathophysiology of sickle cell trait. And third, the Health Resources and Services Administration should work with states to standardize the communication of and use of newborn screening positive results in genetic counseling, and should create a mechanism for communicating this information across the lifespan and ensuring access to needed support and services. Strategy H is the final strategy, and it pertains to the research gaps that need to be addressed for sickle cell disease. And the committee has identified a persistent lack of funding for sickle cell disease, which has resulted in substantial gaps in knowledge about the disease. Federal and private funders, health professional associations, researchers, and patients should collaborate to develop a robust research agenda with priority topics that need to be studied. The committee's recommendation for strategy H is to establish and fund a research agenda to inform effective programs and policies across the lifespan. The time frame for achieving this is 1 to 2 years to create the research agenda and 3 to 5 years to establish funding mechanisms. Areas for future research include societal and structural challenges, current management approaches, healthcare organization and utilization, and developing and delivering the next generation of therapies. And now I'll pass the baton back to Dr. Mary-Claire McCormick.
Thus, in order to make meaningful and sustained progress on implementation, the committee strongly suggests the following. First, there needs to be an oversight body appointed by the Office of the Assistant Secretary for Health, OASH, with representation from across HHS. The current HHS Sickle Cell Disease Working Group may be one option, but there clearly needs to be a group that is familiar with all that's going on across HHS and can coordinate it. Secondly, there needs to be regular assessments to evaluate the progress of implementation. The first should occur no later than 5 years after the release of this report. And finally, as the recommendations have indicated, there are multiple timeframes. 9 are relatively short term in 1 to 2 years. 8 are in the medium term, 2 to 3 years, and 9 for the longer, 3 to 5 years. So we've tried to meet the needs that were given to us in our statement of tasks to outline a comprehensive approach to improving the information and the healthcare of individuals with sickle cell disease and trait. Next slide. Any questions?
Thank you all. We'll now open it up to questions, and as a reminder, you can submit those using the Q&A function in the Zoom chat box. To kick us off for the committee, the first question is, what are some of the proposed changes in the healthcare system to address racism and discrimination facing many people living with sickle cell disease?
I'm not sure who wants to take this one. I'll go first, but of course I welcome everybody's input. Of course, discrimination and racism affecting individuals with sickle cell disease is a reflection of systemic racism and discrimination in our society at large. And this has been put in the forefront by recent dramatic events and by a new age of civil rights movement. And so it obviously healthcare needs to be viewed in the context of all of the challenges that face our society. However, there are a lot of initiatives that the healthcare system can introduce, including training about discrimination and sensitivity training, cultural training, in general, better training of residents and fellows and the physicians who are currently in the workforce about these issues. Increasing recruitment of minority healthcare providers, because we know that for many individuals with sickle cell disease, it's important to be, sometimes it's important to have providers that they perceive and view their challenges in a more direct way. And so a lot of efforts should be made to increase diversity in the workforce that cares for our patients. And I would say that a lot of outreach should be conducted to areas of our country that may not be as exposed to individuals with sickle cell disease, because as you know, most of the population is concentrated in large urban areas. And so these are some ideas, but of course there are many others that we have outlined in detail in our report, and I welcome my colleagues to make further remarks about this very important topic.
No, Dr. Novelli, I think you stated that very nicely. I think that the other thing that I would add or just reiterate and emphasize is that there needs to be attention drawn to the incredible disparities in the healthcare provided to individuals with sickle cell disease, the systemic racism, the unconscious bias that impacts their healthcare, and increasing awareness. And then at the same time, while doing these things, action items that focus on addressing them in a very timely fashion. And I think you're exactly right, Dr. Novelli. The timeline that we have outlined, the committee report, is ambitious but appropriate, because I think that the sickle cell community is ready for action.
I'd like to also emphasize perhaps a more indirect approach. We have very strong statements about quality of care and monitoring quality of care. And that kind of monitoring is the kind of monitoring that would identify disparities and point the way for them to be reduced. So yes, there's the upfront need for explicit training of the providers of care, but also monitoring on the back end to make sure that that kind of training is working out.
Thank you. We do have one practical question for the panelists. Should the timelines be interpreted as being effective in 2020? So for example, if you say an action should have been completed in 1 year, does that mean 2020 to 2021?
Sure.
I agree.
We understand there's going to be an election, so timeline may need to be adjusted. But yes, we do think that many of these things, some of them are already in nascent forms, but we do think many of these things could be performed in a fairly short order.
Thank you. The next question is, how do you plan to incorporate community-based organizations and community health workers to accomplish some of these goals?
Well, I'll start the conversation, and I think that as part of the planning for comprehensive sickle cell centers, that comprehensive doesn't just simply mean the subspecialists from the medical team. It also means engaging community-based organizations and community health workers to be part of that team, because they know the community best, and they can help facilitate the comments and the recommendations from the clinical team, and be a way of providing social support, care coordination, and indeed help the individuals with sickle cell disease gain the kinds of treatment objectives that they need. Kim?
No, exactly. And I just think that the report outlines so many aspects of models of care where community health workers, community-based organizations really need to be incorporated. And then we heard very much, and we didn't have a chance to address it specifically, the need for behavioral health and mental health services to be incorporated as well. And as you know, community health workers can have a unique role, not only in care coordination, medication adherence, transitions of care, both from the ED to home, as well, very importantly, from pediatric to adult focused care, but also in helping us to identify issues that are surrounding mental health and access to behavioral health services.
And I agree. I mean, as any physician working in sickle cell disease will tell you, and I always tell the trainees this, that at least 50% of the challenges that our patients face are non-strictly medical and not strictly related to the biology of the disease, but they are challenges related to what we discussed so far, including stigma, discrimination, socioeconomic, mood, and a lot of other issues. And I find that the community-based organizations are so much better than us medical providers at challenging these issues, are linking our patients with vocational, occupational training, with better housing programs, with help with education and schooling for children. We cannot do all this as medical providers. And so this is where CBOs are fundamental. And I would say they need to be engaged at every step and in every medical decision, because sometimes they have a perspective that we don't have, and that it's critical. And if we ignore that, we're only addressing 50% of the problem.
Thank you. Our next question is, what are the recommendations for addressing pain? We know that in the context of the opioid crisis, overtreatment is a concern, but at the same time, undertreatment and patients being dismissed for reporting symptoms of pain is equally of concern.
I can start with that. I think that what we were trying to do was to develop a model that could address all of the unique issues in the care of individuals living with sickle cell disease, including acute and chronic pain. And I think that I will go back to what Dr. McCormick said in the beginning. The Office of the Assistant Secretary for Health has the unique capability of convening experts. And one of the things that it would be very nice to see is experts not only in sickle cell, but pain management, social service provision, utilization, so that we can really bring high quality care to individuals with sickle cell disease that includes where they're treated for pain, who is treating them for pain, and how they're treating them for pain. Because we also need to address the fact that we need new therapeutics to address acute pain for sickle cell as well. So I think that what you're seeing is we try to establish a blueprint where you could actually address many of the issues related to sickle cell disease by pulling in all of the different components that we outline in our blueprint.
Yeah, and a mother of a child with sickle cell disease said something very compelling during one of our sessions. She said that internists and hematologists, who are typically the front line when treating individuals with sickle cell disease, do not always have the required perspective when it comes to pain. And she said that what we need to use is more of a palliative care approach to pain in sickle cell disease. So what is the long-term effect of the treatments, and of what is the long-term effect of burden of pain on our patients with sickle cell disease, and provide a holistic perspective to the pain that takes into considerations the effect of mood, the effect of cognitive deficits that are critical. Because if you do have a brain dysfunction because of past strokes, your perception of pain will be affected, and you probably will have some degree of nerve damage that also needs to be taken into consideration. And so we will in our report we propose a multidisciplinary holistic approach to pain with a palliative care perspective, among the other measures that have been discussed.
This next question is directed to you, Dr. Novelli. You mentioned on your slides that the committee saw the high cost of therapies as a barrier to access. Other disease states have high cost therapies that are covered by federal, state, and private insurance. Why would therapies for sickle cell disease not be similarly covered? And does the committee have a concern that focusing on the cost of therapies at this early stage of development will reduce the enthusiasm which currently seems to exist in the SCD therapy space?
Well, first of all, I welcome the enthusiasm that there is right now in sickle cell disease, because for many years, as you know, you would go to professional association meetings and there was all this development of new treatments for hemophilia, and we were stuck with hydroxyurea, which is a great drug, but unfortunately the only drug for many years for sickle cell disease. And then recently there's been an enormous interest by the pharmaceutical companies in developing new treatments for sickle cell disease. And so we welcome that, and that's very exciting. What we don't want is a situation where the enthusiasm that comes from having a new drug is tempered by the realization of the enormous cost of that new drug to the payers. And so, for instance, the two new drugs that were approved in November 2019 cost about $100,000 a year. So each injection of crizanlizumab costs $10,000, I mean $8,000 or something similar. So these are enormous costs, and so when a treatment is so expensive, there are occasional barriers to the adoption and to the to having the treatment approved. And so it is important that that at an earlier stage in the development of these drugs, these considerations and cost considerations are discussed and biomarkers developed so that the drug can be utilized in the most cost-effective way. So this is something that is very important. I think that we tend to do only after the drug is approved, and we are faced with sometimes prohibitive costs.
I think hepatitis C also offers a model of this. Yes, it's an expensive drug, but the downstream costs are so high that it warrants the use of such an expensive drug. And I think to the extent that you can document that the new and novel therapies are indeed reducing substantially the morbidity and mortality from sickle cell disease, you will have developed a cost-effective model or cost-benefit model that would warrant such upfront costs.
Thank you. The next question is, how will internal medicine physicians and clinicians be brought into this work, since many adult hospitals do not have a hematology-specific service?
I can start with just saying that I think that there are some federal funded initiatives recently that have moved towards models that include internists, family practice physicians in the care of individuals with sickle cell disease. But I think that we also need to make sure that these providers are able to provide high quality subspecialty care. So there needs to be a model that either links providers to a hematology specialist directly to facilitate delivery of subspecialty care, or that we have a special training model for sickle cell experts that may be included in a fellowship in hematology that allows individuals to come in and do training specifically in sickle cell disease. So I think that our report talks about many of these models, and it's going to take, I think, some effort to convene the appropriate stakeholders so that we can make sure that there are providers for adult sickle cell care. I will reiterate that there's another missing piece though, and it's not just on the provider side, it's the resources that are available to adult providers, providers for adult sickle cell care. And we know that oftentimes the social services that are needed, the community health workers, the social workers, the nurses and nurse practitioners also need to be present along with integrative health and behavioral health services. And those are often lacking in adult programs, and that needs to be changed. We need to provide the resources so they can have all of that as well.
And this is a great area to implement measures that have been recently developed to cope with the pandemic, including telemedicine and e-consults. I mean, having a sickle cell e-consults for those hospitals that do not have hematologists or hematologists who are familiar with the disease would be a pretty low cost and easy to implement solution.
Thank you. The next question is, genetic counseling in sickle cell disease is critical. Did the report have special guidance that could be provided to genetic counselors to best achieve sensitive and practical counseling?
Well, one of the things that we did include was the importance of genetic counselors and the role that they play in delivering important information to those newborns, the parents of newborns with sickle cell trait and sickle cell disease, as well as to prenatal counseling initiatives. So there's so many different areas where we need genetic counselors in our sickle cell community. I think that what the question may be related to is a very specific area that if appropriate models of care are developed and we bring these stakeholders to the table, that it will actually be the genetic counselors that tell us the best thing to do as sickle cell experts. So I think that that's the kind of environment that we're trying to create so that we can address these gaps about the best way to educate individuals and their families about sickle cell disease and sickle cell trait at the various points across the lifespan.
Thank you. Can you speak more about the report's recommendations for ensuring a smooth transition between pediatric care to adult care? And the second part of that, can you speak specifically to Medicaid and Medicare eligibility for SCD and how the report addresses the gap in health insurance coverage?
I can say that at least for in several of the chapters, that gap is specifically pointed out. I don't know that if we've come up with all of the solutions, but some of the solutions that were pointed out was to develop bundles or models of care and payment mechanisms that actually capture individuals across that transition span so that they have continuous health insurance coverage. I think that there are many other disease entities that are grappling with this same issue that we could learn from. Surely, many of us are aware of the American Academy of Pediatrics GOT Transition program. And I think that using some of the lessons and some of the infrastructure that they recommend will help us address policy issues for transitioning youth with chronic illness where sickle cell can also benefit. But we actually pointed out several of these areas as big gaps, suggested some solutions, but obviously need to have convening of experts that can address this long term.
Yeah, as we were talking to Admiral Giroir yesterday, the Maternal and Child Health Bureau also works in the area of transitions with the American Academy of Pediatrics and others. And it's potential for them to develop a toolkit of just about how you go about doing this to the extent possible. So there are a number, we point out a number of organizations that are involved in this and their approaches. And it's a problem across the board in pediatrics, quite frankly, because we are now facing a generation of children who never survived to do adulthood before. So it's not just sickle cell disease, it's across the board.
Thank you. The next question for the committee, are there plans to have SCD-specific calls for research funding coordinated with the NIH and one of its institutes, such as the National Heart, Lung, and Blood Institute?
Well, that's one of our recommendations, that there are some calls specific for sickle cell disease, and there has been a recent effort from several professional organizations to emphasize the need for research in sickle cell disease, such as the American Society of Hematology. So we do advocate absolutely for dedicated funding. And in fact, we stress how funding in sickle cell disease hasn't been keeping up with the pace of funding for other genetic diseases. And so that's absolutely a very important area.
Thank you. And I realize we're coming up on time, so we have time for 2 more questions. The next one is, given the profound inequities in the US healthcare system, where does this report fit in with guiding the actual decision makers at the local and national levels?
So I can start with this. I think that one of the things that we are hopeful about is that the Office of the Assistant Secretary for Health has put the efforts in the Office of Minority Health in a way that we should be able to see many of these play out at a policy level going forward. I think that just with anything where you're dealing with local and state government, will have to address how these policies get adapted. And I think that the best way is to develop advocacy at every level, and to have a national advocacy agenda that can be implemented locally and in states and regions would be one of the ways to start. Because this needs to be something that not only has short-term impact, but can have long-term impact to influence local, state, regional, and national policy.
Thank you. Our final question is, for a long time, people living with SCD have had to be their own advocate or have been overlooked altogether. So what should patients take away from this report? And as these recommendations are rolled out, how do you plan to document the evolution of the sickle cell patient journey that will hopefully be positively impacted by this action plan?
Well, let me start with that one. I think the critical issue will be the development of the kind of information that highlights not only who has sickle cell disease and what their experience is, but also their clinical experiences in terms of care. I think that would be a start in terms of beginning to develop the kind of liaisons that individuals cannot, in and of themselves cannot do, but can join with others. I think the other issue that we heard, which is on the other side of this, is that there are a number of group efforts, such as peer groups, camps, and so forth, that get people together that reduce this isolation and make them aware that they're not the only person with this condition and not the only one who has these problems in getting access to services. So I think it's a combination of both information and more information about what's actually going on, and secondly, beginning to build these community networks or the networking among patients so that they understand that they have their own power of advocacy.
Thank you. And it looks like those are all the questions that we have time for today. And we had hundreds of people join. So I do apologize if we didn't have time to get to all of you. But once you exit this webinar, you'll be redirected to nationalacademies.org/sickle cell disease. Again, that's where you can download a free PDF of the report, and the recording and slides of this webinar should be available there within the week. Once again, I'd like to thank all of our speakers and thank our participants for joining us this afternoon. Have a great rest of your day.